is our, as you guys all know,
Things can begin whenever you're ready.
All right, so we'll go ahead and get started here on time so we can give all of our speakers their full amount of time. So I'm Jason Cook. I'm one of the vascular surgeons at University of Nebraska, filling in for Catherine Holzum, who's our chair. And so this is part of the Midwestern Vascular Society's Medical Student Educational Committee. We try to put forth opportunities to learn about vascular surgery. And so tonight, we wanted to put together a series of case discussions on different types of vascular trauma. And so we have 4 institutions: St. Louis University, Loyola University of Missouri, and Medical College of Wisconsin, that are each going to have presenters discussing types of vascular injuries that they've seen. And after the presentation, we'll have a discussant, which will be a general surgery resident or a vascular fellow, I believe, from the institutions, just asking some questions for us to get some discussion going. Feel free to reach out, use the chat feature if you have questions or topics regarding the presentation that we can try to help answer. And the hope is that this is informal and a nice discussion. So thank you guys all for joining. Our first presentation is going to be a dog bite to the upper extremity, presented by Brian from St. Louis University. Brian, go ahead and share.
Great, thank you. Can everybody see it okay?
Yes.
Great. So I'm Brian Gehring. I'm a first-year medical student at St. Louis University School of Medicine. And today I'll be presenting a case on a traumatic dog bite to the right upper extremity that required a brachial artery interposition bypass graft with the greater saphenous vein, or GSV. So our patient was a 37-year-old male who presented to the SLU ED as a level 2 trauma following a right upper extremity injury due to a dog bite during an encounter with law enforcement's K-9 unit. His pre-hospital course was notable for significant bleeding at the wound site, which required tourniquet placement. Upon arrival in the ED, the tourniquet was removed and there was no active bleeding at the wound, but he was noted to have a pulse differential and with no palpable distal pulse in the right upper extremity relative to the left upper extremity. And given this pulse differential, it necessitated a vascular consult. And on vascular's examination, there was no distal radial pulse and no brachial pulse. And he also wasn't able to move digits 3 through 5 on the affected extremity. And on the right here, you can see a photograph of the wound. And just to orient yourself, that's just superior to the antecubital fossa, just above the elbow joint. Large, complex, irregular wound, measured about 20 centimeters by 8 by 6. And I think it's worth mentioning too that although dog bites superficially can be pretty common injury patterns, when they're deeper and involve vascular territories, they tend to be pretty complex given they feature both a crushing component to them from the dog's jaws as well as that penetrating aspect to it. And so given the pulse differential and kind of a concern for acute limb ischemia, he was brought to the OR, and on wound exploration, there was numerous puncture wounds to the brachial artery. So proximally and distally control of the brachial artery was obtained. And then using a Fogarty catheter, thrombus was retrieved both proximally from the brachial artery to the axillary artery, as well as distally through the radial and ulnar artery. And here's just a little schematic for those that may not be familiar with Fogarty catheters. The catheter is passed beyond the thrombus, and then near the tip there is an inflatable balloon that is enlarged to about the caliber of the vessel, and then it's retracted and hopefully removes all the thrombus. So this was performed in the OR, and then after going both proximally and distally, an angiogram through the arteriotomies was obtained. And here's a photo of them. On the left, you'll see the intra-arterial control going proximally from the brachial artery to the axillary artery, and there's no residual thrombus. And also there's no sign of additional vascular injury there with no extravasation. And then on the right is the intra-arterial control going from the brachial artery down through distally to the radial and ulnar arteries. Once again, showing no residual thrombus there or additional injury to any of the arteries. And so given the extent of the injury to the brachial artery, it was deemed to be the safest to pursue or to go forward with a bypass. Just given the extent of the injury, the injury was not amenable to a primary repair, and the complexity of the wound wasn't necessarily amenable to a patch repair. And kind of going off of why using an autologous conduit for the bypass, just given the trauma, concern for a dirty wound, especially considering it was an animal bite, makes most sense to go with an autologous graft. And so the patient's about 4-inch segment of the patient's greater saphenous vein from the ipsilateral thigh was used. And it was placed in a reverse orientation, proximally and then distally. And after placement, patient had radial and ulnar pulses palpable, and there was also multiphasic signal in the radial and ulnar artery. And then afterwards, the wound was irrigated and all devitalized muscle and non-viable tissues were removed. And then plastic surgery reapproximated the tendons over the brachial artery and placed a drain. You can see that drain placed here, kind of laterally. There's kind of just orienting yourself. There's the proximal aspect of the arm, distal. And that's what the postoperative wound appeared like. And then after the operation, the patient didn't have any complications immediately. He was admitted to the ICU on multimodal pain control, remained stable overnight, and then the next day transitioned to his outpatient pain control regimen, and then was discharged on aspirin. Follow-up about a month later, the patient had no signs of infection to the wound. He did have a palpable radial pulse, but on duplex ultrasound, you can see here he had about a little over a 2x increase in peak systolic velocity to the distal anastomosis relative to the inflow in the graft, which is concerning for possible stenosis. However, given the palpable radial pulse, that was encouraging that there's still distal perfusion. Also, given the location of the wound and the patient stating that they did not participate in physical therapy or really exercising the upper extremity, he was unable to extend it past 90 degrees, given some of the kind of the skin contracture from the wound there. And then just a few takeaways from the case. Although dog bites can be relatively common if they involve deeper vascular structures, they can have pretty complex injury patterns that require surgeons to be pretty flexible in terms of how they decide to manage the injuries, whether that's a primary repair versus patch repair versus bypass graft. It's multifactorial and a case-dependent decision. Also, given the wounds, there's an increased risk of infection and also other complications associated with closure, such as skin contracture. Then also something that I think is worth mentioning too is just the promptness in which the situation needs to be addressed, given the concern for acute limb ischemia and possible risk to limb. And so that's my case. I appreciate the time, and if anybody has any questions or clarifications, please let me know.
Thank you for that nice case. So we have Dr. Sharma, who's going to be our discussant. I don't know, Dr. Sharma, if you have any
Yeah,
sort of questions or discussion points.
sure. Thank you, Brian, for this interesting case. Nicely presented. A couple questions. How many, time had passed by since injury to presentation?
That I'm not
Uh-huh.
100% sure on. Dr. Whitkin, do you know how much time passed from
Sorry,
injury?
can you repeat the question? Sorry.
How much
Can
time?
you repeat the question for me? I've been voice.
Time elapsed since injury to presentation.
It was fortunately very brief. This was probably under an hour. This gentleman, this brings up so many ethical, moral, and other issues. He was wanted, and the federal marshals went after him. He was wanted for the murder of 3 individuals. He was hiding in a home. They denied that he was there. They told him that they were going to set the dogs on him, and that they would find him if he was there. Those dogs at the canine unit are not trained to bite. They are trained to kill. He was lucky they grabbed his arm. And I've seen a couple of other of these types of injuries from these animals that are trained. And it's not infrequent that you will get some severe traction injuries or dislocations. It's almost like a farming injury. They try to spin the individual around from that. Doctors got tourniquet promptly. I came to us immediately. The first thing the ER does is to make sure that it really is what is billed, take the tourniquet down and see if it's bleeding. And the tourniquet went right up and went straight up to the OR without any imaging. So we were within the first hour.
Okay. And I was just curious, at presentation, he was not able to move some digits. So whether intra, were there any nerve injuries also, like along with brachial artery and like,
Oh yeah. Yeah, he had a chunk taken out of his median nerve and his ulnar nerve was transected.
okay, okay. And blood, and that was not repaired, I'm assuming, at the,
Plastic surgery, didn't do much with the median. They said that he had enough fascicles intact. They were comfortable with that. The ulnar nerve had a gap, and they tagged both ends with the idea that maybe someday he could get an interposition graft with that. He is unfortunately or fortunately incarcerated in maximum security prison, which is why he's received no physical therapy, and pretty much right now has an arm that's locked in a 90-degree position.
I see, I see. And I was just curious also, like how much of the segment of GSP was used and which was the vein situation surrounding? Was there like an option of using, the same arm vein of,
Pretty much every vein he had in his antecubital fossa was destroyed. And we were down to past the confluence of where the bifurcation was for radial and ulnar, clearly. So we would have been doing a venous anastomosis for a vein interposition for a venous restoration, to a radial and to a brachial. I did the arterial portion first, used the 4 centimeters in the arm extended, was a little concerned about soft tissue coverage over that. Plastic surgery was involved. We tried as best we could to come horizontal across that antecubital fossa. Some of the bite limited our options there. That, we were not very tight in the forearm. He did not get a full forearm fasciotomy because of the timing, and the venous drainage through collaterals appeared adequate. So at that point, we elected to stop.
okay. All right.
I think for the purposes of time, we'll move forward, but I think it brings up a really interesting point. For us in vascular surgery, you have to be able to expose these vessels. You have to do them in a way that's consistent with the ability to heal, especially across joint spaces. And obviously, this is a tough situation, especially in a patient who doesn't potentially have great access to, healthcare and the ability to get physical therapy. Obviously, it's a really tough area to have a contracture and an inability to extend. But still a great presentation. So thank you guys. Moving on to our next one. The next presentation will be from Loyola University, blunt traumatic aortic injuries, done by Karen.
All right, can everyone see my screen?
Yep.
Just go into presenters mode. Sorry, 1 second. Okay, there we go. So hi everyone, I'm Karen. Today I'll be talking about a case on blunt thoracic aortic injury managed by TVAR. So a patient is a 60-year-old male who presented as a level 1 trauma after a motor vehicle collision. He was an unrestrained driver with all airbags deployed. He was found to have thoracic spine fractures, multiple rib fractures, bilateral hemothorax, forehead lacerations, spleen lacerations, and a blunt thoracic aortic injury. Past medical history of hypertension. Of notes, patient saw cardiothoracic surgery earlier this year for chest pain and shoulder pain, and his ACT angio at that time showed a small ulceration less than 5 millimeters on the medial curve of the proximal descending thoracic aorta around the area of the subclavian artery. No intervention was indicated at that time, and the surgeon recommended a repeat angio and follow-up in 3 months. And his otherwise his medications, he's taking aspirin, no anti-coagulants, and some blood pressure medications. He denies any alcohol, tobacco, or drug use. So his other injuries that he sustained, in addition to the grade 3 blunt thoracic aortic injury with pseudoaneurysm that was picked up on the initial CT. He also had, like I said, hemothorax, multiple rib fractures, spine fractures, and this grade 2 spleen laceration and bilateral forehead lacerations. And just to go over the classifications of the different grades of thoracic aortic injury, grade 1 is classified by a intimal tear. Grade 2, there's usually an intramural hematoma, and then with grade 3, which is the case in outpatient, there's a pseudoaneurysm, and if not repaired urgently, it can progress into a grade 4 ruptured aneurysm. On physical exam, patient had palpable bilateral carotid, radial, femoral, DP, and PT pulses, normal sinus rhythm, chest with ecchymosis, cap refill was less than 2 seconds, notable bleeding forehead lacerations, and sensory motor function was intact, a GCS of 15. His vitals were stable in the ED. Then this is the initial chest x-rays. As we see, he clearly has a widened median sternum. And then on initial CT, we see the separation of the layers of the aorta, and the sac was contained, so no contrast leakage into the median sternum, telling us that it's not a ruptured aneurysm. Here just more images depicting the grade 3 pseudoaneurysm and the flap. So for assessment and plan for a 60-year-old male with past medical history of hypertension and a 5 millimeter thoracic aortic ulceration who presented as a level 1 trauma after a motor vehicle crash, imaging shows type 3 blunt thoracic aortic injury with a large pseudoaneurysm. Our plan was an emergent TVAR with possible left subclavian coverage and possible subclavian artery bypass and possible laser fenestration. For the procedure, we actually chose not to give intraoperative heparin given his multiple injuries and this bleeding laceration with concerns of intra-abdominal bleeding. And then we used a Gore thoracic branch endograft with a 12 millimeter portal limb with coverage of the left subclavian. We used a standard egg French sheath with right femoral artery access and perclose placements performed. We also used an ultrasound guided access of the left radial artery that allowed us to advance a snare to capture the wire from the femoral access. We also used a intravascular ultrasound was performed to evaluate any injuries. Then we placed a 22 French dry seal over the through and through to accommodate for the TBE device system. And then afterwards, we buddy wired a double curve ludicrous to Lundaquist to the ascending aorta. At that point, the device was placed and deployed, following which we also placed a 12 mm portal limb via the left radial access. Then we used a glide catheter to cannulate the portal gates. And after placing the limb, the portal limb, we used a glide catheter to identify the left vertebral artery. Completion angiogram showed good seal and patent head vessels, including the left subclavian artery with no endoleak. And the entire large bore sheath time was 18 minutes. Here is the angiogram before stent placement. And then this is the completion angiogram showing good seal proximally with no endoleak and patent left subclavian artery. So for our discussions, I want to focus more on blunt thoracic aortic injury management. So for grade 1 and 2, we know that medical management has been shown to be superior to operative management. However, for grade 3 and 4, TVAR is the preferred interventions, which has been shown to have a lower morbidity and mortality compared to open repair. And grade 4 injuries usually require emergent intervention. Interestingly, with the Society of Vascular Surgery recommendations of repairing all injuries greater than intimal disruptions in the context of BTAI, one study found an almost 200% increase in the use of TVAR from 2003 to 2013, which really raises its concerns about whether we're overtreating BTAIs. And in fact, there is a growing evidence for non-operative management of select cases of type 3 blunt thoracic aortic injury, particularly those with small pseudoaneurysms, provided that continuous imaging surveillance is maintained. And then in terms of the timing of interventions, despite a lot of advancement in TVAR and under management, the timing for grade 3 injury repair is still debatable. There are evidence that indicates delayed repair, so repair over 24 hours from the time of injury has been shown to have improved survival compared to patients who received immediate repair. There's one study that looked at 28,100 BTAI patients from the National Trauma Data Bank, and they found that patients undergoing delayed repair actually had better survival outcomes compared to those who received repair within the 24 hours. And one of the reasons could be that delayed repair allowed for stabilizations of concomitant injuries and optimizations of patient physiology, which could lead to better outcome. That being said, the timing of TVAR should be highly individualized. So an outpatient, he actually received repair within the 24 hours, just given of the concerns for his underlying aortic disease and no other life-threatening injuries that require immediate repair. And then I also wanted to touch upon the safety and efficacy of intraoperative heparin use during TVAR for type 3 BTAIs. So the American Academy of Cardiology and AHA both states that the use of intraoperative heparin during surgery or endovascular management should be individualized, so there's no definitive guidelines as to whether or not we should give heparin in this case and how much to give. So in outpatient, we chose not to administer intraoperative heparin given his concomitant injuries and this concerns for intra-abdominal bleedings. And then a brief literature search showed that intraoperative heparin has been associated with reduced inpatient mortality and a lower risk of lower extremity embolizations without significant increase in bleeding risks. And this is true for patients with high injury and severity or head and neck trauma as well. There's another study that looked at patients with moderate BTAI with stable intracranial hemorrhage. And then even in those cases, administering heparin was found to be safe and did not worsen the intracranial hemorrhage. However, another study showed that there was no significant difference in thrombotic or bleeding outcomes or mortality rates between those who were heparinized and those who were not, who had BTAI undergoing TFAR. So, and they also found that the primary benefits of not receiving heparin was actually like in a shorter time to repair. So the mean time to repair in the fully heparinized group was 3 times longer than the non-heparinized group. So given the current evidence, there is still not a definitive guideline as to whether or not to give heparin. And it's really based on the surgeon's discretion and the patient's presentations. And the lack of heparinization actually appears to be safe and potentially a faster alternative in patients with multiple trauma. To wrap up this discussions, I want to touch upon the long-term surveillance for these patients. Patients undergoing TVAR after BTAI, they're recommended to get imaging at 1 month, 6 months, 12 months, and then every 2 to 5 years to monitor for complications such as endoleaks, stents migration, or aortic remodeling. And these long-term complications are less common in patients with blunt thoracic aortic injury compared to those who are receiving TFAR for, say, aortic dissections or aneurysms. However, it's still important to monitor these patients long term. Thank you.
All right, thank you for that nice presentation. I think it's admirable to do a thoracic branch in 18 minutes. I think most of us spend half that time getting the wire wrap out. But it is a very nice procedure, especially for these bad aortic transections where you want to maintain perfusion. Dr. Rowland from Medical College of Wisconsin.
Hi, very nice job, Karen. That was a fantastic discussion. Yeah, I was actually going to ask you just a little bit about sort of the general practice down in Loyola about subclavian coverage. You know, there's controversial literature. You know, some people will favor that. Other people will favor just covering the subclavian, given that the risk of immediate ischemia is about 2.5%. So is the practice down there to typically cover the subclavian, or what's sort of the general consensus there? And how's the patient doing post-op?
Yeah. Thank you for your question. So I know in the initial plan, we consider doing a subclavian bypass. However, in this case, the patient post-op had no complications, did not develop any left upper extremity ischemia or no symptoms of any indications of stenosis of the subclavian. And given the completion angiogram showing very patent vessels, we were fairly confident that the bypass was not indicated, at least in this case. However, I think given we'll continue to monitor and follow up with this patient if he develop any complications further down the road, I'm sure that's a consideration. But just given the from his initial presentations, that was not an indication for us to perform that.
Perfect. I guess my last question for you was, you know, these patients typically, there's a high degree of impact that is required to get a grade 3 aortic injury. And oftentimes, exactly like you described, these patients come with multiple other injuries, rib fractures, splenic injuries, intra-abdominal injuries. You mentioned very nicely that, you know, you can wait to repair these injuries if it's needed. So my question for you is, had this patient had intraoperative or abdominal bleeding and was hemodynamically unstable, would you have fixed the aorta first, or would you have performed an exploratory laparotomy first in this patient?
So for outpatient, I think we had suspicions or concerns about intraoperative abdominal bleeding. However, he was hemodynamically stable at presentation. So I think for us, the decision was made to repair the aorta before all the other fractures. He underwent other orthopedics surgeries after the aortic repair. And I think given that he was hemodynamically stable with no bleeding, like obvious bleeding at presentation, it was safe for us to go ahead and repair the aorta first. Just given, and he is an interesting case, just given his prior suspected aortic ulceration that the CT surgery actually decided not to pursue or repair at that point. So he's not the clean cut like BTAI patient that we see. He had actually, I think, a predisposition to developing the pseudoaneurysm, and that I think extra layer of patient history also require a more urgent treatment of the aorta.
Yeah, that was an excellent presentation and excellent questions. I think that, it's very infrequent that you get to see such a classic presentation of the pseudoaneurysm with a BTAI. So that was kind of really nice to see. And I think that, just kind of getting at that question, it really kind of depends upon what injuries they come in with, right? If you're taking them to the operating room to do the aortic repair, it really depends upon how much other stuff is going on with them, depending upon, where you order that. And so a lot of times if they come in with major intra-abdominal injuries that need an XLAP, they'll get that XLAP first, and then you'll kind of proceed with the aortic repair afterwards. Really just, it's patient specific. But nice job. Nice job. Here.
Okay.
All right. Yeah. Go ahead. You can keep it.
No, I was gonna have us move forward just in the interest
Yeah.
of keeping the time.
Yeah.
So our next one will be an axillary gunshot wound from University of Missouri, by Yijin. Hope I'm saying that right.
Yeah, you are. Thank you so much, Dr. Cook. Gonna share my screen here. Okay. So my name's Yijin. It's very nice to see everyone. I'm a rising third year at the University of Missouri.
And I'm Anne. I'm a newly upgraded fourth year, also at University of Missouri. So we're going to present this case together. It's an axillary brachial artery bypass using saphenous vein in a penetrating trauma. All right, so for this patient's presentation, we have an 18-year-old male. He presented to an outside hospital with a single gunshot wound to the left arm, and there were no other bullet wounds visualized. There were signs of arterial bleeding at presentation to that hospital, and so they placed a tourniquet. He was unable to maintain his airway, and he was intubated and then transferred to the university hospital so that he could have a higher level of care. And his time from injury to presentation was about 3 hours. And so at arrival to our hospital, he was evaluated by acute care surgery. He had signs of hemodynamic instability. And then when we took down the tourniquet, he also didn't have any palpable pulses in that left upper extremity. And then based on his initial imaging and physical exam, we went ahead and placed a chest tube and then took him up to our trauma OR for definitive management. And that's where vascular surgery was met and consulted. So his initial findings in our chest x-ray here, you can very clearly see the bullet that is lodged in his chest cavity and the subcutaneous air, pulmonary contusions, and then we went ahead and placed the chest tube for that hemopneumothorax. And then here's his CTA. He has a really abrupt cutoff of his axillary artery kind of at that brachial axillary junction. And then if you watch it here, kind of, we don't see any recanalization all the way down through the hand. So especially with younger patients, we weren't exactly sure what our distal target was going to be. So we needed to manage this kind of emergently. All right. And then this is just his 3D reconstruction. You can very clearly see that he had clear arterial injury. And so we went ahead in the OR ideally, this presentation would have been managed in the hybrid room so that we could possibly do some endovascular repair as well. But just given his hemodynamic instability and stuff and ACS being the primary, he was in the trauma room. So we didn't have any access to fluoroscopy for this. And then just his laundry list of injuries prior to our surgical management. So we found that he had complete occlusion of the distal axillary artery. There was also irregularity noted of the left axillary vein. And then other injuries, he had a small hemopneumothorax, he had pulmonary contusions and lacerations, and then fractures of his ribs and a non-displaced scapular body fracture. I think that's where the bullet kind of landed.
So, following the operative course of this patient, we started with an infraclavicular exposure of the left axillary artery, followed by a distal cut down for brachial artery control. Directly exploring the hematoma revealed a near complete transection of the axillobrachial artery junction. And at this point, it was noted that this was a significantly destructive injury, with the axillobrachial artery junction being frayed. The ends of the arteries, although they were held together by just one string of adventitia. So several centimeters of the artery had to be debrided, and it was decided that end-to-end anastomosis of the artery was not possible. So the decision was made to use an interposition graft instead. And just a brief note on the anatomy here, we see the subclavian artery coming out of the scalenes and running under the clavicle. The axillary artery is broken down into three parts based on its relationship with pec minor, with the first part being proximal, the third part being distal, and the second part being deep to the muscle here. And the brachial plexus as well is near this region, particularly the cords of the brachial plexus runs with the axillary artery. So any injury to the artery can also increase the risk of injuries to the nerves that branch off the cords of the brachial plexus. And finally, we have the axillary artery going into the brachial artery as it passes teres major. So notes on this operation in particular, after identifying the proximal and distal ends of the injured artery, first balloon thrombectomy was performed on the axillary and brachial arteries in addition to a brachial vein repair. The right great saphenous vein was harvested and an interposition graft was placed from axillary to mid-brachial artery. And a prophylactic forearm fasciotomy was also performed by hand surgery. So indications for this prophylactic fasciotomy was that the ischemia time for this patient was greater than 4 to 6 hours at this point, and there was a combined arterial and venous injury for this patient, all of which indicating that a prophylactic forearm fasciotomy. And this is typically performed by either orthosurgery or plastic surgery at the University of Missouri. And after this procedure, flow was restored with a palpable left radial pulse. So post-operatively, on day 1, the patient was maintained on aspirin and low-dose heparin. And on day 2, the left radial pulse remained palpable with perfusion intact to the left hand. The patient was transitioned to aspirin monotherapy and followed with vascular, was established in 2 weeks, and the patient was discharged on post-op day 3. 2-week follow-up, the left radial pulse remained intact, although there was some limited left arm extension and flexion of the digits, potentially indicating reduced ulnar and radial nerve function in this case. Here's some pictures of the patient post-op. You can see the left arm here well perfused, the left hand well perfused, although there does seem to be some residual neuromuscular disability. So opening up the conversation to the management of subclavian and axillary arteries in general, these types of injuries, especially those that are close to the subclavian artery, may be difficult to manage due to the proximity to both the clavicle and the brachial plexus in those areas. So a recent review, a multi-center review by Waller and colleagues, had examined 223 patients with these types of injuries and came to certain conclusions regarding the management approaches and the trends in the management of these types of injuries over the last 10 years, or over a 10-year period between 2014 and between 2004 and 2014. One of the first conclusions that the group had came to was that open repair still remains essential for these types of injuries, with open repair being performed in the majority of cases, especially for transections and greater than 50% vessel lacerations. Now, one of the hypotheses that the group had was that an endovascular approach to the repair of subclavian and axillary artery injuries may increase in frequency over time. But in fact, this was not the case. We didn't see an increase in frequency of endovascular approaches being used for these types of injuries, although an endovascular approach was used for certain circumstances, such as pseudoaneurysms and intimal injuries, with no difference in outcomes versus open repair. And finally, the group did find an increasing frequency of a hybrid approach being used, particularly consisting of balloon catheter control, followed by typically open but also stent repair. And this may be assisted by the increasing accessibility to hybrid ORs. The hybrid approach, as you can see, went from almost 0% in 2004 to almost 20% in 2014. So, in conclusion, there remains to be a role for open endovascular and hybrid approaches to the management of subclavian and axillary artery injuries. The open repair is preferred in a majority of cases, and particularly for severe cases where there are hard signs of arterial injury and complete vessel transections. Endovascular repair may be indicated in certain circumstances, but as you can see from the data, an endovascular approach, there still remains to be many cases where the anatomy is not amenable for that. And finally, we may begin to see an increasing amount and an increasing frequency of a hybrid approach being used, particularly consisting of proximal endovascular balloon occlusion followed by open repair, especially with increasing access to hybrid ORs. And with that, I thank you for your time.
Thanks for that presentation. It's pretty interesting that you can get hit by a shotgun and go home on post-op day 3. That is impressive. For our discussion, we have Dr. Hilaire.
Hi there. Yes, wonderful presentation on axillary brachial injury. I think you thoroughly laid out the management of this, and I kind of wanted to hone in on one of the points you brought up in terms of hybrid ORs. In this particular case, you mentioned the ACS team being primary kind of dictated which OR this went to, and in this case, a non-hybrid OR. If that was the case where you had that hybrid OR availability, how would that have changed your management of this case?
Yeah. So I think from my understanding of a hybrid OR was available, proximal control may have been established endovascularly first and then followed by open repair. So as we can see in this particular case, I think we just did this case open, but if hybrid ORs are available, and we had discussed this with Dr. Nog as well, that endovascular control of the bleeding and endovascular control of, especially for the proximal portion of the injury, would have been done before any open repair, but then open repair would have been done after. And I think overall for proximal subclavian artery injuries, it tends to be preferred. I think it's a little bit faster to get endovascular balloon control of any bleeding in that proximal subclavian region before open repair.
I think too, in this case, and Dr. Nag just add on, but we were very lucky that there was that little piece holding the artery together. So they were able to find, the two ends and get control that way. But if that wasn't the case, then I think the endovascular also would have given us a little bit more flexibility on how we could get that proximal control.
Yeah, thanks, Jen and for a great presentation. That I agree with those points. So for us, we treat traumatic vascular injuries very much in a multidisciplinary fashion. And there's a high sort of percentage of transfers from other hospitals. So we sort of have to, kind of figure things out on the fly as patients arrive. So this patient ended up going to a room that was not on a radiolucent table, unfortunately, which is pretty unusual because usually our trauma team is good about going to the hybrid room if it's available. So I don't remember if there's something else going on that night, but in any case, so I agree. So for proximal control, I think a balloon would have been nice, but we didn't have that option. So we just did an intraclavicular approach. I think this case it's hard to appreciate without pictures, but it sort of highlighted why endovascular approaches can be nice because doing the dissection was challenging. As you saw, there was a ton of sub-Q air in every plane, and this kid's axilla was violated. So getting into that hematoma was a mess. And then also the proximal anastomosis was in a deep dark hole that essentially only one person could look in at a time. So just having an appreciation for like the anatomy in that space, I think kind of demonstrates why having endovascular approaches available can be helpful.
Yeah, I was gonna say kudos to you all for doing that. That sounds like an incredibly painful operation to do, to be in that axilla after we get violated. So I'm glad that you brought that up.
Yeah, very nicely done. I'm gonna go ahead and move on to our last one. Our last one is from Medical College of Wisconsin, and it's a blunt popliteal injury from a trampoline accident, presented by Jessica.
Okay, let me just share my screen. That up. Okay, so hello everyone. My name is Jessica Chan, and I'm a first-year medical student at the Medical College of Wisconsin. Today, I'll be presenting a blunt traumatic popliteal injury after a trampoline accident. So our patient today is a 39-year-old male with a chief complaint of right leg pain. So he arrived via EMS for acute traumatic injury to the right lower extremity after the patient stated he jumped and landed incorrectly at a trampoline park. His past medical history was remarkable for daily tobacco use and alcohol use. And then on physical exam, it was noted that his dorsal pedis pulses were 2+ on the right and also on the left side. And also his right lower extremity was in a traction device after being brought in from EMS. And also the patient was complaining of pain to palpation along the proximal tibia and fibula region. So the vitals here are listed, as well as the labs. So the next step was to order some imaging. So here is some initial imaging that we can see of the right femur and the knee. And of note of the imaging, no acute fracture or dislocations were found, so there were no suspicious osseous lesions, and the joint spaces and alignment were maintained. So this made us kind of question, what was going on with the patient. So here's some more imaging. Also of note, there was no acute fracture or malalignment identified in the right leg, as well as a small ossification adjacent to the fibular styloid. Those would be chronic in nature. So from this imaging, you can't really tell what is going on. So on reassessment, the patient still complained that he had persistent pain to his right lower extremity. And now, following up with him, it was noted that the patient's right foot was actually palpably cooler than his left foot, and they were not really able to palpate a distal pulse. So the next step was already to consult vascular surgery, as well as pending a CT angio of the right lower extremity just to rule out vascular injury and order an MRI. So here on the pre-op, we can see a CT of his right lower extremity arteries. So as you can see kind of on these images, here's his right leg and his left leg. You can tell there's an occlusion of the right popliteal artery at the level of his distal femur. So a lot of decreased opacification of the dorsal pedal and posterior tibial arteries in the foot compared to his left foot over here. And here was imaging of the MRI done of his right knee. And I'll go over here to just kind of see what the pre-op key findings were. So on the CT, as I said before, there was occlusion of the right popliteal artery. And then on the MRI from the previous slide, we noticed that there were ACL as well as PCL complete tears, and then also meniscal tears to the medial and lateral aspects. So the diagnosis preoperatively was this patient had acute limb-threatening ischemia, as well as a right posterior knee dislocation and right multiligamentous knee injury. So in order to manage these type of cases, there's a couple considerations that we could think about. So first is revascularizing his lower extremity, and there's a couple of different types of graft options. So you have endovascular repair, which is limited in trauma, the risk of stent kicking with knee motion, or you can do an open repair, which is preferred in trauma with better long-term patency. And then for the type of bypass conduit options, you have the prosthetic synthetic ones, as well as autologous ones, which we used in this case, harvesting from his greater saphenous vein. And then afterwards, fasciotomy. was done, and this is just for prolonged ischemia of greater than 6 hours and to deal with compartment pressures in his leg. So I said the choice that we did for this patient was a femoral popliteal bypass graft using a reverse saphenous vein of the contralateral leg. So over here, I kind of have an image of what is going on. So you have his artery and it's being blocked. So this is a surgical procedure that basically helps restore blood flow to the lower leg. So basically, the saphenous vein is taken from the inner thigh of the other leg and then reversed before using it as a graft in his leg that was occluded. And the reasoning for this type of graft versus the synthetic one that I mentioned, there's multiple reasons, but one, it's just a gold standard in this type of trauma case, and it has a lot of higher patency long-term rates compared to a synthetic graft, as well as lower infection rates and complications. So over here, I kind of have a chart showing kind of the different characteristics between a vein graft, which is what we use, versus a synthetic graft. So as I said, the infection rate is lower, the patency is more superior because it's more long-term, and this durability is more excellent because it adapts over time since we are using the patient's own veins over a synthetic graft, which can be prone to thrombosis or occlusion over time. And then also vein graft may be technically more demanding since a synthetic graft is easier to use, but due to all these other positives, this was found to be a better option. So for operative intervention, as stated, the goal was to revascularize the lower extremity with the reverse saphenous vein graft. So here were the steps of what occurred. So first was the exploration of the right popliteal artery through a medial leg incision, then exploration of the right superficial femoral artery through the right medial thigh incision. And then we harvested the contralateral great saphenous vein distal to the thigh from the other leg. And then a reverse saphenous vein interposition graft was done. And then after all this, 4-compartment fasciotomy was completed through medial and lateral incisions. So for the last step, what is a fasciotomy? So this is a type of surgery to relieve swelling and pressure in a compartment of the leg. So tissue that's surrounding this leg is usually cut open, and this is to help relieve a lot of pressure buildup here due to compartment syndrome. So fasciotomies are critical because of prolonged ischemia in an area can cause massive tissue swelling, which is known as compartment syndrome. So doing this can help decompress the 4 different compartments of the leg, which include the anterior, the lateral compartment, the superficial posterior, as well as the deep posterior compartment. And this is important because it prevents irreversible muscle and nerve damage. And this is especially critical in high-risk trauma, as in, delayed reperfusion with or from the popliteal artery injury. So some key indications for doing this is ischemia time greater than 6 hours, if there's tense compartments, any motor or sensory deficits, as well as absent distal pulses despite revascularization. So after this intervention was done here, we have some images that you can see of the CT scan of the right knee post-operatively. And more importantly here, we see a duplex scan of the right knee. So a duplex ultrasound was done post-op, and this was to confirm the patency of the right femoral popliteal bypass. So as you can see, going down the vein, there's like blood flowing through it. So this was to confirm the operation afterwards. And for post-op course and management, so on the post-op day 2, closure of the right lateral fasciotomy was done. On post-op day 4, closure of the medial aspect of the fasciotomy was done. And then finally, post-operatively on day 6, the patient was discharged. So he was discharged with the right lower extremity, knee splint, and walkers and crutches to go along with that. And then his pain was managed with Robeson and oxycodone as needed, as well as gabapentin nightly. And then, as mentioned in his past medical history, he had a history of tobacco use. So now to help him with the tobacco cessation, since, as we know, smoking is bad because it restricts blood flow and damages like a lot of blood vessels and arteries and increases the risk for clot formation, Chantix was given to help him stop his tobacco use. So here are some major learning points from this case. So anatomy-wise, this dealt with a popliteal artery, and this is an artery that's tethered at the adductor hiatus and soleus arch, which is prone a lot of times to traction and shear injury. So in this presentation of the patient, it was a blunt trauma since he fell off and injured his leg incorrectly from the trampoline, causing a posterior dislocation. So oftentimes in these type of presentations, the limb is usually cool and pulseless, and this kind of points towards a vascular emergency. And online and on literature kind of said that these type of cases are rare. They're less than 1% trauma, but this is limb threatening. So it's important to see if there is anything wrong with that. And then the other major learning point is to assess the vascular status and knee dislocations. So this includes having timely imaging to know what is going on, because the amputation risk goes up to 86% if after 68 hours there is no revascularization in these types of cases. And then also another important point is just the multidisciplinary care between ortho, trauma, and vascular, just to proper communication between all different types of departments. So in conclusion, in these types of cases, early recognition and prompt intervention is very important, because as stated on the other side, amputation risk increases really highly. So by having early recognition and intervention, you can limb salvage. And then the type of graft that we use, the reversed greater saphenous vein grafts, these remain reliable for traumatic bypasses. And in low velocity trauma cases, such as these trampoline accidents and injuries, these can mimic high energy injuries. So it's always important to maintain clinical suspicion in knee dislocations, regardless of the mechanism, to see the bigger picture of what is going on. And that is my presentation. Thank you all for listening.
Thank you so much for that presentation. It was very nice. I think popliteal injuries are very, very difficult areas. And obviously, as you saw, right, what do you think was the difference in the physical exam where there was a palpable pulse and all of a sudden no pulse? Sorry, Dr. Sorer is our discussant. I probably took the question right from him.
This was probably my first question, but I'll ask two more.
Yeah, so the difference was, well, initially, when the nurse noted it, she said that there were distal pulses in between. So it could, I don't know, maybe have just been I don't want to say like accidental reading, but maybe like over time, in the time in between, due to the ischemia, it was harder to feel the pulses, especially since it's in the lower extremity. So then later, when they realized from imaging that there wasn't any fracture or anything that could be seen in the X-ray, they had to go and kind of reassess what was going on. And then they noticed that the other limb felt cooler, and with that time that passed, no distal pulses in that leg.
Go ahead, Dr. Sorer.
So just to follow up on that pulse exam, is there anything you think your team or you could have done at that time or this secondary survey or before CT at bedside that could have been an objective marker that, you know, because a pulse exam is dependent on my finger. I could say I felt it and someone else did not feel it. So what could have you done instead that is simple and easy?
Yeah, that's a great question. So I guess another test that could have done bedside is what's kind of called a ankle brachial index. And basically these are kind of like quick, non-invasive ways where you can assess the perfusion in like the leg or lower extremities in this case. So they could have calculated that to kind of see if the value was consistent with like limb ischemia. And that would have probably been helpful in this case of like an acute trauma setting as like a early screening tool, especially while you're waiting for like definitive imaging such as, you know, a CTA.
Excellent. Yeah. My other question that I had for you, did the patient present with any symptoms of ischemia? Because the initial symptom was only the popliteal fossa pain. So do you think that was a distracting injury? Did the patient have symptoms of actually that will lead you towards, popliteal dissection or thrombosis or no?
From everything I read, nothing of that was noted. It was more so that the patient was complaining of this pain, and on imaging, nothing was found, which is why it was reassessed.
Yeah, Jessica did a great job presenting this case. This was actually a case I did a couple years ago. It was our, I think, second or third traumatic vascular injury of the night, and it was just, he actually wasn't even a trauma activation. He was, downgraded by the ER, and so that was part of, I think, what delayed this. And so again, it's the evolving vascular injury because these are traction injuries. I don't know about you guys. I'm always tempted to try to like see if I can throw a wire down there. I've tried it once, and someone who was BMI of 43 and actually slipped on the ice. Like you talk about a low velocity injury. She fell and had an open dislocation of the knee prosthesis. But I feel like you can never get through these like sheer injuries. I'm always unhappy. So I'm tempted. I've done it for a couple like intimal injuries. Usually it's more penetrating or something if you can get a lumen, but these traction injuries, I almost always do open.
Yeah, I think sometimes you can come from above and below and cross and snare to get through. But I think one of the things when you cut down on that popliteal artery, it is blue, it is angry. I mean, you can stent it and probably get away with it some of the time, right? But that is a very angry artery, and it's probably not going to do as well long term as doing a traditional open bypass for them.
Yeah.
Many of these may be palpable when they show up, right? And there's enough of an injury, there's enough damage that over 30 minutes to an hour, plus, it'll thrombose.
Especially because these people don't have collaterals. These are young, healthy patients, normal arteries, and it's a bad spot. So yeah.
One of the things that you didn't discuss, though, was the positioning of the patient with regard to an unstable knee. And this is something that I think all of us struggle with, right? So you have a patient with an ischemic leg with an unstable knee joint who's in traction. And who's first? Are you first? Or is orthopedics first? Do you put a shunt in? Do you hope that your bypass is the right length and tell ortho not to pull too hard?
I go first and I try to leave some laxity, and then yeah, that is, the positioning is tough because this whole knee joint moves as you're trying to move the patient. And but yeah, and then I always make sure myself or my fellow or one of my teammates is there in the operating room to examine the patient before we leave, because I don't trust ortho.
Yeah, there's nothing like them pulling and putting the patient in traction and all of a sudden calling you back for rapidly expanding hematoma as they have pulled your proximal anastomosis off. But the good news is the leg will be the right length, so that'll be great. So, all right. Well, thank you guys. We're 3 minutes over, but I think we had 4 fantastic presentations, and I'm glad we got time for questions. So I hope this was helpful for people.
Yeah. I just want to say thank you to everyone. Was a little bit late getting on the call, but all the student presentations, you guys did an excellent job. I appreciate the involvement of all the discussants and residents. I really think that this helped overall from the standpoint of this discussion. So thank you for all being involved. I hope that you found it useful as well. And for all the attendings that helped out with helping the students prepare, thank you too. All right, so I really appreciate it. Thank you all for being involved. Okay. I think that's all we got. Take care.
Okay, thank you, everyone.